Unmute yourself kindly.
Now you can hear me. Yeah. Okay, so I continue, and feel free if the presenter joined, I would be happy to stop. So I started with the theories, then I gave you some names and some type of work that people are doing, from Tom Levy's work to Neil Krauss and Carol Graham and James Jackson. Now I want to move to some landmark studies that can help you use those data and ask your questions. One is Agile Families. Agile Family and Child Wellbeing Study started at 1998, and the eligibility for the study was either low income or unmarried couple who were giving birth to a kid, to baby, not necessarily their first baby, but giving birth to a baby, and being followed, both parents, the kid, or if the parent is not available, the caregiver, being followed for 15 years from 98 to 2015. This data set is publicly available, so you just need a few clicks to get the data. And there are advantages of this study. One is, in most studies, minority populations or non-white populations make the smaller proportion of the sample. However, for fragile families and child well-being study, whites are the minority group in the study. So from 5,000 individuals, around 3,000 or 2,700 are Black. Then around 1,500 are Latino, and something around 800 families are white. So you get a large distribution in the Black families who marry, they move out of marriage, they show upward educational mobility, employment mobility, and those. This study has generated probably 500 papers, and 2-3 very interesting studies are being conducted now. One of them is, now that people have detailed data of the past 15 years, now NIH has funded a group of investigators to look at the mechanisms that explain cardiovascular health. So it is a Framingham study of youth or young adults, and all those families who were not lost are now being studied for cardiovascular health. That is one. There is also another supplement of the study being conducted by University of Michigan, which is around 500 of those kids are undergoing brain imaging. So now you have 15 years of detailed data that, did the police stop you? Did the police stop your dad? Did your teacher was nice to you, was not nice to you? Did you have an uncle coming and read books to you? All those thousands of questions now can be correlated with brain imaging data. And again, one big advantage of that study is that you have more Black and Latino people than white. So in most of our studies, we write that, yeah, we had imbalanced sample size, low, underpower in the subgroup analysis, not in this study. This is the time frame of the observations of the study. It started at birth, then age 1, one observation, age 1, age 3, age 5, age 9. Age 9 was the last time they collected data on fathers. Because these families were mainly non-married, for that reason, in many cases, the father was non-residential or the relation was not continuing. So it was highly expensive for the study to continue collecting data on the non-residential fathers. So NIH decided to discontinue collection of data from age 9 forward. So you have both parents' data for 0, age 1, age 3, age 5, and age 9, but you don't have dad's data at age 15. Probably I have maybe published 20 papers from this data set. It's just amazing data set and collects data on mental health of parents using DSM criteria, not measuring depressive symptoms. You know which parent has depressive disorder, and you collect data on details of parenting and economic experiences and stressful life events. You have all those during these years, and also a large number of biological measures. This is the team of Fragile Families. Before, like 2 years ago, Sarah McLaughlin, Irv Garfinkel, and Ron Mincy were the PIs, and now many of them have been retired, and the major Fragile Family studies has ended, and now the supplements are going on. So the study has 2 new investigators, and Ron Mincy is one of my co-authors in many of my papers. So you also have another very unique study, which is the longest and largest exclusively Black family follow-up study in the United States. So at 1996, at Iowa and Georgia, 2 groups collectively around 900 families were followed for 18 years by Rick Gibbons at University of Connecticut and Ron Simmons at Georgia. And other than multiple observations in the study, and now they have a lot of biological measures, they have full genetic data of these kids. But one big advantage of this study is half of this sample was Black kids in Black families who were being raised in a majority white area. And there was another one, a Black kid in a Black family in a majority Black area. So you can.
Oh, sorry to interrupt you.
No.
If you're aware of instrument associated with substance abuse and drugs in any of those studies, please mention it as well, that our student knows that if they want to study substance abuse, what kind of data they are dealing with. Thank you.
Sure, very good question. Okay, here, starting from here, Agile Families, there is data on substance abuse disorder, like 0-1 DSM-based substance use disorder of the mom 1 year after birth, in the dad 1 year after birth, and any additional observations, like at age 3 of the kid, we know who had a substance use disorder. And for age 9, we have a lot of behavioral profile of the kid, like who is more active, hyperactive, has used some substance. And then at age 15, we have a full behavioral measure in addition to the substance use disorder of the parent. But as I said, at age 15 of fragile family, only mom or the caregiver is a part of the study and the kid. Okay, so you can do a lot of stuff, cool stuff with substance use disorder of the parent and finally substance use of the kid 15 years later in fragile families. You can also, this data set, FACTS, which I was talking at Iowa and Georgia, has collected considerable substance use related measures, and maybe half of the publications from this team is on substance use. And the team has had very much interest in showing how discrimination, because they are psychologists. Ron Simmons is a sociologist, but Rick Gibbons is a psychologist. So a major question for this team has been, what are the psychological mediators of substance use in response to discrimination? And what are the gender differences in this? So if a Black boy in Iowa is being discriminated against compared to a Black boy, the study, doesn't have a white control sample, but a Black boy who is discriminated in Georgia, then 4 years later, turning to use substance much more than the person who is not discriminated against. And what are the psychological, so was it like hopelessness? Was it sadness? Was it anger? And what are the differences for different types of substances and for different genders? There are a number of papers they have published on these nuances of pathways from discrimination to substance use by gender. And then another very unique study is PSID. PSID is the previous study, FACTS, is the longest exclusively Black family study in the United States and is only 18 years. PSID, panel study of income dynamics, is the only study in the United States which has followed 18,000 individuals for up to 50 years, 50. So 2 years ago was the 50-year anniversary of the study. The study has been conducted by University of Michigan Institute of Social Research, ISR, and the change in family composition. First of all, they have oversampled poor people and immigrant people. So if you are interested in economic mechanisms of later health and behaviors, including substance use, like tobacco use, with over 50 years of follow-up, with an oversample of people who are experiencing poverty, this is the study. And it's 5 minutes to get the data set that you want. It has a very advanced search tool. You go there, you search substance or tobacco, and it says we have data at age 15 and 20, and then you click and you download and you get education, income, and anything you are interested. So now let's talk about intervention studies that people have been doing. Dr. Friedman asked me the previous session, have you done intervention? And these are some interventions that people are doing related to health disparities, including substance use. Probably the most famous and most successful one is a Strong African American Families program, replicated several times, showing that it is effective. So I can say probably 20 papers on this intervention. showing effective, and also scholars have shown that there is a dosage effect of this intervention. So if you miss 3 sessions of the whole curriculum, you are going to show a lower effect. And as you know, establishing dosage effect is one of the important mechanisms to show causality. So not only it works, its different levels show proportional effects. So that is one area. Then a smaller one is fathers and sons study, and that has also substance use and impulsivity and substance use related outcomes. Another one is fathers and sons. It's being conducted by Cleo Caldwell, one of my main mentors at Michigan. The first study was conducted in Flint at 1998, and that was a quasi-experimental, theoretically based, culturally oriented, gender-specific intervention. So it was bringing non-residential fathers and their African-American sons. So there was no girl and no mom in this study. And you know how much more difficult is to do parenting on dads than moms, and how much it is more difficult to do it on sons than daughters. So this fathers and sons intervention showed promising results in the quasi-experimental intervention in Flint around 20 years ago. There were replications with nutrition and other behaviors like diet. And recently, like 2 years ago, there was an intervention with 400 families in Chicago. So Southside Chicago was receiving a fathers and sons intervention with a very interesting caveat, and that is, this time, the outcome was not just kids' outcomes, was also fathers' outcomes, because we had observed that becoming a better parent for non-resident fathers not only helps the kids, but also helps themselves. So this is an NICHD. Previous one, and Flint was a CDC study. This is an NICHD study with randomized trial design, South Chicago. Substance use, a big outcome in this study. There was also moving to opportunity study, which was probably the most important study, housing mobility intervention. It provided vouchers to 3 groups. One group didn't receive any voucher. One group received Section 8 housing vouchers, so they were still staying in some low-income areas. And one of the groups received voucher and was able to move out of the area, which was poor. And the study started at 1994, and they followed 4,600 families. And the first observation was 2002, around 6 years after the intervention has started. And then between 2008 and 2010, around 10 to 15 years after the intervention. So there has been some effects, but the effects were smaller than expected. And the results, as many of you may know, were highly specific to gender. So they observed that moving out of poverty is more protective for girls than boys. And they showed that some of the boys have already established, and here is not about race. You have low income, white people in the study, low income, Black people, Latino, all groups. So this is not about race, but they observed that the kids, the boys, had already established close friendship and affiliation with high-risk groups before this moving to opportunity happens. So when they were asking a composition of the risk of their friendship, boys didn't report that much new friends after moving to the opportunity, but girls did. So the intervention may be more effective in some domains on girls. Another very interesting observation is what I have on this slide. I will read it for you. For girls, extended neighborhood disadvantage generates a risk. So if you have a girl in a low income area, it's not the immediate network or disadvantage of that girl. It is the extended neighborhood. However, for boys, the risk was mainly related to localized, concentrated, proximal disadvantage to boys. So it is proximity of disadvantage is worse for boys. And then, the early childhood is a major determinant of health and child development and brain development. And Kimberly Noble at Teachers College at Columbia has published a lot on social determinants of brain development. So she has published a lot on how income changes the thickness of the cerebral cortex and how income or parental education changes the amygdala size or hippocampal size or thalamus size, and also their function. So Kimberly Noble is the main figure in the area of social determinants of health and kids' brain. Now, what are they doing with Greg Duncan? Remember, in two hours ago, I said Hackman has published and got Nobel Prize showing that early education of the child at risk is probably the solution. And I said Duncan later showed that there is an overestimation of that benefit and the effect has not been that large. So now what are they proposing? They are running a income assistance intervention for low-income mothers at the time of the birth of their baby in these 4 metropolitan areas: New York, New Orleans, Twin Cities, and Omaha. And they started their intervention between 2018 and 2019, and they assigned between $33 to $20. So why did they decide to give $20 to some of the families? Because they want to undo the contact effect, the placebo effect. If you don't do anything to the control group, many people would say it is not the effect of that $300, it's effect of the calls that you gave them and you said, how are you doing? It's the time for an interview. So because they wanted to, it is really the amount of the money or the income assistance, not the frequency of the contacts. So there are 1,000 moms who are receiving either $20 or $333 per month for 40 months after birth. And this study, I believe, and then there would be brain imaging and all those. I think this is one of those studies that is going to really be like a revolution. You would see that if you prevent poverty, absolute poverty, then the size of brain would show in response, some changes in response. And then local here is Compton Pledge. Compton Pledge is just starting as the largest guaranteed income program in the country with 800 pre-verified residents in Compton. And the eligibility of this study is irregularity or informally employed residents. So either you are informally employed or you are irregularly employed. You can be an immigrant of any status, legal status. You can be undocumented, and you can be formerly incarcerated. So 800 of these families are receiving between $300 to $600 per month to reduce them from absolute poverty. And they have raised 2.5 million so far, and they are hoping to receive donations to increase this work. This is also providing some evidence suggesting that what would be the health consequence of bringing people out of poverty. So I discussed
Before you go on, Dr. Assari,
yes.
Are they collecting any data on substance abuse?
Not this one. I am not aware of any data collection on substance use on any of these two income interventions. I'm not aware of.
Thank you.
You are welcome. So now I gave you some theoretical background on if you want to do inequality, what would be the theoretical framework. You can go to Sir Marmot and bring the idea of social determinants. You can go to Link and Phelan and bring fundamental cause, and you can even bring racism as a fundamental cause and so forth. Then I showed you some cool research by some famous or established researchers and some younger researchers, but they were doing great work. Then I showed you some unique studies that you can go and get the data and use, and some other. So far it has been on theory, some researchers, and some research studies that you can go. Now I want to give you some tools for online analysis of some of these inequalities, and I am going to introduce three websites. One is CDU GIS Lab, and if you Google CDU GIS Lab, you get to a website that you can look at the geographic distribution of some of these health problems, including COVID, and some of the inequalities of resources. So based on the area of interest that you are interested in, death, hospitalization, COVID infection, CDU GIS Lab, directed by Dr. Paul Robinson, is an available tool for you, and you can go ahead and look at the geographic distribution. Another very helpful tool for looking at inequalities in a broader level is a new index that University of Michigan Poverty Solution generated. This is just brand new. And you go to this website and you look at deep poverty and areas that are affected by deep poverty, and you can relate it to some of the health outcomes. Mohsen, I don't know if they have any substance use or alcohol related. But the issue is you can do the same thing. You can go to web and search GIS mapping of substance use. And even if they don't have it, I'm sure you can map these two together because you can download the file as an Excel sheet here. And you also get any level of granularity. You can get the US, you can get the states, you can get zip codes. And then finally, another helpful atlas or website is Neighborhood Atlas by Amy Kind from University of Wisconsin. Amy Kind was here at Charles Drew like 7 months ago giving a talk after giving a talk at UCLA. And I had the privilege to talk to her. So they have developed this very famous variable called ADI, Area Deprivation Index. So you can get a quantitative score that includes education, income, unemployment, rent of the neighborhood, crime rate, and all the adversities that you can think of. So you get one score that reflects all. So you get an overall adversity effect, and then you can decompose it. For example, in the ABCD study, they have residential history data of every of these 11,000 kids. So the variables are, first of one of them is the same, area deprivation index. So you get a score, highly correlated with social determinants and also brain of the kids. And some of those brain mechanisms are highly relevant to substance use. You know, cerebral cortex thickness is a predictor of substance use. The connectivity between amygdala and cortex, especially prefrontal cortex, is a strong predictor of substance use. So you have millions of variables at the brain level for each node and also the connectivity between all those nodes at the ABCD study. And also you get this area deprivation index. After you establish that effect, you can go ahead and decompose that to see if it is area level availability of drugs, or it is area level liquor stores, or it is area level drug related crimes, or drugged drivings and alcohol driving under influence. You get, just imagine, 11,000 kids followed for 10 years, designed by NIDA. So that means every substance use measure that you can imagine, you should be able to find it. Starting from the time that none of these, like there are 5 kids have already used substances in these 11,000 kids. Almost no one has started. And a big part of these families have substance use disorder in their family. And you have that measured. You have substance use disorder in mother, you have it in dad, you have it in uncles and siblings and brothers and sisters and distant family members, and then you have these neighborhood related variables. So if you are interested in investing on a brain study that can get to the end of the mechanisms that link poverty and inequality to substance use, ABCD study is there. So I don't know if I should continue, because I can continue a little bit about the work that around 20 other people have done. But for now, I want to give a chance to students to ask questions, and then if we had time, I will go ahead and tell what each person of these crowd that I'm showing has shown. So please, Christina, Dr. Friedman, do you want to go ahead and give the students a chance to ask questions?
Yes, please. Thank you so much. Students, can you have any
Yes.
questions for Dr. Assari?
Hi, I have a quick question.
Sure.
So is there a different approach if you are studying inner city versus like really rural youth?
What do you mean that you are asking a theoretical framework?
Yeah, like theoretically, if you wanted to study like an inner city population versus a rural youth population, how would you approach it?
Okay, very good point. So, you know, first of all, race is a big confounder here, because there is a huge difference in the composition of rural and suburban and urban areas in the United States. So then that means you need to bring race-related theories to the picture. Then you, by studying poverty at rural areas, we are talking about social isolation and not having access. That is another thing. And then there are large proportion of Blacks who are living in rural areas in South, in Delta region, in deep poverty. So then that means then there is a literature on Delta region. So what does it mean to be Black in a southern city like Georgia, or Atlanta, or compared to being Black and poor in a rural area in South US? I have not even touched that literature. So this is not an area that I can advise you. But I'm aware of one paper at least that has discussed epidemiology of mental health disorders in rural African American people in the United States. And if you are interested, I can forward that paper to you. So if just one colleague has published and compared rural areas to urban areas regarding mental health epidemiology by race. But I'm not aware of much other work. So social isolation comes to the play issue. Then you need to, education is much lower in rural area than urban areas. So then you can also bring the work by Ross and Mirovsky, suggesting that if you do not have high education, emotion regulation, and behaviors, and the access to power and access to resources and type of jobs, so that type of work. But I'm not highly qualified to comment on that.
Thank you for answering my question. I'll message you my email so that I would be interested in reading that paper.
Please.
So yeah, I'll message you right now my email.
Okay, good. Other questions?
So if you were a teenage African-American young male, what would you do to try to improve your future?
Very good question. Wow. Okay, first of all, you need to tell me my gender, because I think racism in the United States is highly sexualized. So tell me what would be my
male.
gender. Okay, so I would know, assuming that I am an educated one, meaning that I am aware of a structural racism, and I'm aware that there is block against my upward social mobility and my well-being is stronger. There is a larger block against me, even compared to my sisters. So that is so I'm thinking with you. I am saying it now. So I would know the difference that my life is being forced by because of my race and sex, which are not in my favor, even when compared to my same race by different sex and gender peer. That is one. The second one, I assume that I will also go to the literature because I told you, I assume that I'm an educated one. And I would be aware that for upward social mobility of Black males in the United States, a baby face helps, and a masculine face is a risk factor. I would know that if I have, this is extremely sad, I would know that I have a higher chance of becoming a Black male CEO if I have a baby face. The literature is called teddy bear effect. And I would have very harsh time in my institution if I am very large, tall, masculine Black male. So the point is, I would know my risk. Then I would also know by the literature that each level of discrimination is going to be more hurtful to me because Black men are worse at dealing with discrimination when you compare them to Black women. So there is not only Black males across age groups. Black males get more discrimination and they do worse with it. And they turn it. This is interesting because there is a dichotomy of the effect of discrimination on outcome, either being eating related outcome or substance use related outcomes. And there are around 10 papers showing that the effect of discrimination on substance use outcomes is larger for Black males and Latino males. And the effect of discrimination on BMI related outcomes, being eating disorder or obesity or all those, overeating, are larger for Black girls. So again, I would know that if I am going to be discriminated against, no question, even if you are Obama, it is going to be worse, then I am not terribly good as a male to handle my discrimination. And the highest risk across different outcomes is my substance use. So, okay, I would know that. Now, from here, I know education would reduce my risk, but not as much as my counterparts. I would know that the only way is upward social mobility, but I would know that despite social mobility, because the structure of the society, I would still be at risk of depression and other outcomes. So in responding to your question, I would inform myself, I would be aware of differential effects in me because of the society, but still I would not be disappointed and invest on upward educational mobility. And I would definitely not engage in premarital sex, because we observe that a large of the health inequality, or a big chunk of health inequality between Black and white shrinks smaller and smaller in married couple. So I would save childbearing after marriage. And that's it. Okay, another one. Men are worse with healthcare utilization. This is just a rule. Black men are also worse than black women in healthcare, for healthcare utilization. Lot of papers. So I would have a reminder on my cell phone, or I would ask someone. It is interesting. They say black parents take care of their health, not because of themselves, but because of kids and their social network. That's a literature around that. So I would ask people around me to remind me and to motivate me to go do prostate exam or something, because I am male, highly risk of not taking care of my health. I'm a black male, mistrust and poor access, and then also not own health as driver of health-seeking behavior, but also my social network and a strong effect of surrounding. And finally, I would know that religiosity and social support is a double, like, serving resource for my health. So I would get to social support and religiosity if I was black.
Shervin, relative to Dr. Friedman's question, tell us a little bit about the literature on resilience.
Mohsen, I think we should have a break.
Okay,
Sorry.
should I, Dr. Friedman, should I say it or I should not proceed?
Let's do it for future. It's already, it's 3:20. We're supposed to end at 3:15. We want to give people a break before the session. Thank you so much. And you a little bit answered my question, although not that much.
Because
okay.
my knowledge is limited on that regard. So that is what.
I think maybe we'll talk about more intervention and less characterization.
Yes.
Let's give a break. We'll start back at 3:30 with Dr. Bazargan and Dr. Cobb on the workshop.
Thank you very much, everyone.
Thank you. Thank you.
I remind everybody that the next section is optional. I know it's Friday afternoon, so just wanted to let you know it's optional. You don't have to stay if you.
But it will help you if you want to try to write a grant.
Yeah.
Oh, absolutely. Yes.
Oh boy, Sharon, great. Shervin, great job. Thank you.
Oh, sure. My pleasure. Thank you very much.
Yeah, so, especially for a student who are not aware of secondary data sets, this is quite important. At the same time, we have resources here at CDU. Dr. Shaheen is here. Shaheen is Director of Epidemiology Biostat, core of Access program. So she will tell you that if you're interested in secondary data analysis, we will purchase that data for you. And we have expertise in Dr. Shaheen's shop to help you to analyze the data sets, secondary data set. Anyway, so Shervin, thank you again and congratulations for your study being reviewed by Harvard University. What was the center name?
Anti-racism and policy, race policy, something like that. They wrote a full one-page summary of it. And such a good summary. I would not be able to write that quality summary of my work.
First, I thought that you wrote that.
No, I didn't.
Wow, they wrote it for you, so this is great.
Yeah, that theory paper is like 50 pages, so it is crazy long. The original paper that the theory paper, 50 pages. So someone was patient and going through it.
Congratulations again, Dr. Assari. That's well deserving.
Thank you, Sharon. You know, in several of the studies that I reported, you were either first author or co-author. So
That's
great.
okay. I'm happy to see MDRs get more exposure as it should. So this is wonderful.
Great, great.
So,
I know my boss was worried I wasn't going to show up, so I'm letting him know I'm here and I'm.
you know, one of our speakers didn't show up.
Oh, really?
Yeah.
Oh, no.